a pediatric surgeon and vice chair of research in the Department of Surgery at Rush University Medical Center in Chicago. Dr. Shah is a very busy woman who's changing the world every day. She leads system-wide efforts in clinician wellness, faculty development, and sustainable surgical care. Dr. Shah does work in greening the operating room, reducing medical waste, and rethinking clinical practices to align with environmental sustainability goals. Her work hopes to bridge clinical excellence with climate conscious innovation in healthcare systems. So please welcome Dr. Ami Shah. And as she's getting her slides up to share, I just would like to invite everyone to post your questions in the chat, and I will collate questions for Dr. Shah at the end of her presentation. And after the talk, there will be a survey sent to you about how we can keep making this climate and health learning series better. So please welcome Dr. Shah.
Thank you, Dr. Sims. I'm really happy to be here today and really excited actually to talk about reducing waste. I'm hopefully going to take you on a little journey with some humility of how I've been working in this space, and hopefully offer some ideas to everyone about how you can do this at your institution, or just maybe you can tell me how to do it better at mine. I think we can see the slides okay? Okay, great. So my objectives today, hopefully, is to discuss some barriers and solutions to our sustainability work, discuss sustainability through a research lens. I think Dr. Sims mentioned that I am the vice chair of research, and I really believe that putting our work out there is what sort of helps change hearts and minds and get some more people behind what we hope to do. And I wanted to also discuss the utility of LCAs in sustainability research. If you guys are experts in LCAs, awesome. If you don't know anything about LCAs, hopefully you walk away invigorated to learn more about them. So how I sort of started in sustainability work, I think, is not unique. I had children, and I will fully admit, before I had children, I never really thought about this. But I had children, and I started realizing what was happening in the world around me and thinking about what future I was going to leave them. And I had a lot of nightmares. And I was worried that they were either going to inherit the Mad Max world. And I know I'm dating myself, but for those of you who haven't seen it, post-apocalyptic, desert world with no water. Or I thought they were going to inherit Waterworld, another bad Kevin Costner movie where the world's basically flooded and they live on little islands. And I'm like, my children are so weak, they will die immediately, and they have no resiliency. So I was like, what do I do? How do I tackle this problem? And I had a lot of eco-anxiety, and I didn't know where to start, didn't know where to go. And around a little bit after that time, I was fortunate enough to go on a mission trip to sub-Saharan Africa, and I noticed that the picture on the left is the mission trip in Africa, and I was doing an inguinal hernia repair there, and you can sort of see basically what I had on the field was everything that I had to do the operation. And I was like, oh my gosh, I have 4 instruments. How am I going to do this operation? And the surgeons there just sort of laughed at me, and they're like, you Americans. And then we're able to sort of, honestly, I learned a lot from them to guide me through and make me think critically about what I really need to do in operation. And the picture on the right, or whatever side of the screen you're on, is what I use currently to do a laparoscopic inguinal hernia repair in the United States. And this is just a case from last Wednesday. And I'm like, and when I came back from the mission trip, I was like, oh my gosh, how much waste do I create to do this relatively straightforward operation, knowing I could do it with so much less? And this is actually after I've asked probably 6 or 7 times to continue to compress down my operative tray, what they open for me. And this is still what I get and just sort of what I'm stuck with. And so as you can see, the amount of waste we generate, and this is a slide stolen from Cassie Thiel, the amount of waste that we generate from the operating room was just staggering to me. So I was like, okay, this is an area that perhaps I can make a difference, that perhaps is accessible to me in my day-to-day life to frankly combat my eco anxiety. And I know you guys all know this, but um, healthcare is almost 20% of our national economy and 8.5% of our carbon emissions. This is a little bit of old data from Dr. Eckelman, and I'm sure we're higher now. And we are an outlier in terms of cost and greenhouse gas emissions. And so how this shows up for me specifically is in the operating room. We know that while the operating room has a small footprint, it really has an outsized amount of emissions. And the operating room is really important, as you guys all know, to a hospital's revenue. It's about 60% of the hospital's revenue. And operating rooms are responsible from, depending on where you look, anywhere from 25 to 50% of a hospital's total carbon footprint. And this is a complicated way in which it's in charge of the carbon footprint. As many of you may know or may not know, the HVAC system, the heating and cooling system in the operating room is highly regulated. So there's a lot of air exchange. There are minimums in the amount of air exchanges that need to happen. There are temperature regulations, moisture regulations of what needs to happen in this semi-sterile to sterile environment in the operating room. And so a lot of the emissions from the operating room happen in terms of HVAC. Also, my anesthetic colleagues in the operating room have really led the charge in terms of trying to make our operating rooms more greenhouse gas efficient. You may or may not know that desflurane was initially developed in the 1980s, and then in the 1990s sort of became the anesthetic of choice. But desflurane is given to a patient, exhaled from a patient, not really changed. It goes out into the atmosphere and lives in the atmosphere for 14 years after it's released. So all that desflurane we were using was basically unchanged and then released into the atmosphere, living there for 14 years and contributing to the greenhouse effect and contributing to global warming. It has a global warming potential of 25,000 times higher than that of carbon dioxide. And so our anesthesiologists have really led the charge that now desflurane is not the standard of care and really getting rid of desflurane from most hospitals and going to anesthetic gases that are better for that. One of the charges I've seen at many children's hospitals right now has been to decrease the amount of nitrous oxide that is used. While nitrous oxide has a relatively low so the problem with nitric oxide is that it has a relatively low potency, but we need higher concentrations to achieve the clinical effects. And so it's 270 times more potent than carbon dioxide as warming the environment. Like we always think of carbon dioxide as so bad, but here are these anesthetic gases that we're using that are 25,000 times to 270 times more potent than carbon dioxide. And the problem with nitrous oxide is that at our institution, we looked at it comes in on a big gas tanker. They put it in the tanks and then it's piped to each of our individual operating rooms. And what we found at our institution, and this is similar to what's being found at many institutions, is over 90% of that gas that we buy is lost in that pipe system. So the hospital is only able to use 10% of what they buy because it's lost, and it's just lost out into the atmosphere and the environment. So many places have stopped using nitrous oxide, and at our institution, we've changed to using nitrous oxide that are in the little roller tanks, like an oxygen tank, in each individual room, instead of having the piped systems like we do for oxygen and carbon dioxide. One of the other areas that I'll focus on a little bit and talk about in this talk is single-use surgical devices. This has sort of exploded in surgery, and probably this all started sort of around the time of the HIV pandemic. So when HIV prior to HIV, and I just learned about this recently, we were using still glass syringes and reusable needles. And with that concern about sort of the safety of these, can we adequately clean these things? How do we reuse these things? Really single-use surgical devices and single-use packaging and plastics really took off. And we didn't really think about what is the other harm of using so much of these single-use surgical devices and all the packaging that they come in. And is it really better for the patient? Is it really more sterile? Is it really better than the reusable option? And we see a lot of that in surgery. And then, of course, the other problem with the operating room is the amount of hazardous waste that's generated. I'm not sure how aware you guys are of this, but we can't recycle anything from the operating room once the patient's in the operating room. So anything that's open before a patient comes into the room, we can theoretically recycle, reuse, do things with. But the moment a patient hits the room, even if they're still awake, anything that goes into the garbage is treated like hazardous waste in terms of how it's disposed of. And so this can the amount of and volume of waste that can be generated can be quite substantial. So I found out about all these problems. I learned all these things, and I just wanted to give props out to my sustainability team because I was like, oh my gosh, I've learned about the problem. Things are so terrible. What in the world do I do? And I was lucky enough to meet Ian Hughes, who's still at Rush, and Katie Pittman, who's moved on to Healthcare Without Harm. And they were two people who were, just as they described themselves, sustainability nerds, who were like, how do we work within the system here to really change things? And they weren't clinicians. They had one other clinician that was sort of volunteering their time in monthly meetings. And they were like, hey, go look at these two sites. So just to call out to Practice Green Health and Healthcare Without Harm and see what you might be interested in, see what projects we can start. And before I joined the team, they already had some great success in getting rid of desflurane. We were doing a lot of blue wrap recycling. They were starting to have the conversations around decreasing nitrous usage. So I was really lucky to meet them and be able to pair with them. And now Ian has a team of 4, still small but mighty, but slowly really making progress at Rush. So I went to the Practice Green Health website and I saw this infographic and I was like, awesome, this is so cool. There's so much stuff we can do. We've already sort of done the anesthetic gas recycling. We had already had a fluid management system. And I was like, great, what's the next big number that I can tackle? Because I'm a surgeon, I can do it. I'm going to be so awesome. And so I was like, HVAC, that's amazing. Let me learn everything about HVAC. And it should be so simple for us to turn off the lights and turn off the HVAC system. At Rush, we have over 30 operating rooms. I think we have somewhere close to 50. I don't know the exact number, but I was like, oh, it should be so easy. Like the ortho ORs that don't run on the weekends and nights, it should be so easy to turn off the lights in those rooms. And we have operating rooms in 3 separate areas in the hospital. And there's only one main OR that we use for night and weekend cases. So those other 2 areas, it should be so easy to shut them down. I'm going to show how much we can save. This is going to be environmental awesomeness. It's going to go so great. And what happened was that it was a total failure. I completely bombed on this project. And what I learned is just what a complex environment many of these things can touch. So we had knowledge, we had some construction, so we knew how soon we could ramp up the HVAC. We knew how well our ventilation system was working. But what I didn't know was a lot, but also what are the regulatory burdens around HVAC systems and how we could be cited. And that, oh, wait, some of our OR sensors aren't working. And it's going to be a $50,000 thing to even just get our OR sensors working to be able to even consider, turning off our HVAC systems at nights or on weekends. And this was immediately post-COVID that I was having these conversations. I don't know if we're ever really post-COVID, but it's right after the first sort of round of COVID when we were sort of starting to recover. And there's a lot of concerns and valid concerns from infection prevention and control. Like, what does this mean? How is this going to happen? And so this HVAC project didn't go anywhere. But I'm a surgeon and I'm nothing if not persistent. And so I asked, what could I control? And one of the things that I was like, I can control or at least talk to people about are preference cards. So for those of you who aren't surgeons, preference cards tell us what that would tell are cards that we theoretically develop that tells the operating room staff what to have open and ready for each operation. And also theoretically, surgeons love preference cards because that means that that operation is completely efficient. Everything that we need to do that operation is going to be ready and waiting for us. And this is an example of what a preference card could look like. It has our glove size, what instruments we can need, what suture we can need, what dressings we put on, how to get the patient ready for surgery, all of these little things. So in theory, it's the operation distilled down to its most essential components so that we can perform this operation quickly and efficiently. And what I started to realize is I was like, wait, I don't think I've ever been asked about my preference cards. I don't think anyone's ever, I don't even know how my preference cards were originally developed. With a couple of med students in my institution, we did a survey of our surgeons and what do they think about preference cards? What do they think about these things that should really make them super excited and they should be ready to fix, update, and have those things the most efficient as possible? And what we found out is that almost 50% of them had rarely or never updated their preference cards to the point where they hadn't even seen their preference cards. And when we asked them to think about what's in the room compared to what's on their preference cards, almost 99% of them said that some of their cases had unused items on their card. So that means those are sutures that the nurses were opening that supposedly the surgeon wanted because it was on the preference cards that they didn't need. That means single-use surgical devices were open on their tray, open on the back field, and they had never asked about them. That there were instruments that they never used that went through the entire sterilization process time after time after time that they never used. And all of them felt that more frequent updates would reduce this waste, but they were like, we don't know how to do it, and it's too hard. And we asked them as well, do you know anything about the environmental impact of the items on your card? And 62% said that they didn't feel like they had any knowledge of the environmental impact of items on their cards. So we sort of had this black box in that surgeons really cared about what was on their card, but they just felt like it was too hard to update it. They weren't able to do it. They didn't know how to do it. So we're like, okay, we've surveyed you. You told us it's really hard. Let's do a qualitative study and find out what are those barriers to environmental sustainability in the operating room. And we sort of expanded out our the people that we interviewed. We interviewed surgeons, anesthesiologists, residents on both sides for surgery and anesthesia, CRNAs, nurses, and surgical technologists, and said, why, if you care so much about this and you see that these things are not efficient and there are a lot of things we don't need, what do we do with this? So we asked them what are the barriers, and they said that they didn't have the resources, that they didn't have the knowledge to pursue environmental sustainability, and there was underlying worry that something that we could do in the name of environmental sustainability would affect patient safety, which was interesting. And we asked them, well, what are some of the facilitators, some of the things that could help with sustainability in our operating rooms? And they emphasized that really that there needs to be some surgeon leadership within the OR to reduce the supplies and then spread the awareness of the environmental and economic impact of our surgical waste. And what was interesting is that when we sort of pulled this out a little bit further, the surgeons were like, I don't think that's really our job. So there was a desire for surgeons to lead this charge from other people, but from the surgeons themselves, they just felt like they didn't know enough about it, and to a certain extent, like they didn't necessarily feel like it was their job. So we were trying to figure out, okay, well, many people are telling us that they don't have enough information and they don't know how to figure out what the environmental impact of a device is. Like it's just sort of a black box. And it was like, okay, how can I figure out the environmental impact of this? What do I need to learn in order to be able to communicate this to my colleagues and everyone else? And so what I learned is that there was a great way to learn about this that I had no frame of reference for. And this is an LCA, or a life cycle assessment. And as you may know, a life cycle assessment is a systematic method for evaluating the impacts of a device from its cradle to its grave. So what resources do we use to harvest that device, those materials, to then transform that device into something, or those materials into something that we can use? How do we use that device? And then finally, what happens to it when we're done with it? And so a life cycle assessment can be pretty complicated, but the most exciting thing for me is what we can get out of a life cycle assessment. And that is really, it falls into the life cycle impact assessment. What harm or good things or bad things, or what happens to the environment from this device, from using this device. And so I just wanted to put a very much a thank you to Dr. Thiel, Cassie Thiel, who runs an LCA course. And I took her LCA course, and it sort of really opened my mind. And I will say very much, I am still a beginner novice in terms of doing LCAs, but it was revolutionary for me to learn about it and then how to do that within the healthcare environment. So I was like, okay, now I can figure out the environmental impact of this. What's something that I really care about, that I wish that I could see changed, that wouldn't possibly be too difficult to do within the healthcare setting? So, like any research, my first project was spite research. um, Pre-COVID, we used to be able to wear cotton caps that showed off our personalities. Then there was a change, and we had to go to these very ugly bouffant caps. And then during COVID, when we couldn't get enough PPE, we were able to go back to cotton caps. And then COVID was over, and then we had to go back to these really ugly bouffant caps. And so I was like, there's been a lot published in the surgical literature, because it's obviously a thing for surgeons, and for anesthesiologists. And so it was really spite research. And so what I did was, okay, we've talked about the cost of bouffant caps, we've talked about sterility, we've talked about, shedding of microbes from the surgeon to the patient. But no one's ever really talked about the environmental impact of these bouffant caps, these plastic made caps, versus reusable cotton caps. And so I found at our institution itself, we use 1.2 million of these bouffant caps that are produced in China and purchased by our system. And then they come over on freight, via a big tanker ship over to us, and then come to the distribution center and then get distributed to us. And I was like, wow, we're throwing away 1.2 million of these bouffant caps per year. Maybe I can save the institution money, prove everything, and get people to no longer, I thought naively I could change the institution. And so you can see on the right, are a couple of my colleagues who were kind enough to help post about being so happy, looking at themselves in a cotton cap, and how much they would prefer that. So and I just wanted to show you what an LCA could sort of look like. And what we did is we looked at the disposable bouffant cap, and we came up with a reusable cotton cap. And we looked at everything from the raw materials that went into that bouffant cap, to the manufacturing, to the distribution, to the single use, to solid waste management. And for the reusable cotton cap, we assumed that we would use one cap over, that each person would have 3 caps, that they would launder them about once a week. And we had to include that laundering data within our LCA, to really make this sort of, as best we could, a head-to-head comparison about what would happen. Some of the other data that we had to gather, and this is a table from the software, that's the most used software, which is called SEMA Pro. And this is just not to, give you palpitations or that you have to read all this, but this is just an example of all of the information that we gathered. So we gathered what are these bouffant caps made of, how are they transformed to make them from polypropylene granules into this bouffant cap. How do they get from that factory to the port? How do they get from the port to us? And then what happens to them when we get rid of them? And we included the packaging that was associated with the bouffant cap, and then we included everything that went into making a cotton cap and the laundering of a cotton cap. And it was an interesting process to figure out what is the most used washer and dryer in the United States. How much water do they use? How much energy does a dryer use? But really neat data to figure out. And we also, this is just also some assumptions we made, and you can argue any of these assumptions in terms of how many cotton caps are being used in the United States every year. So we found a paper that said that surgeons on average do anywhere from 79 per surgeon to 755 procedures a year, with the average being 417 procedures a year. And we went from looking at an operating room that's got 4 people in it, from just the anesthesiologist, the surgeon, the scrub tech, and the nurse, to an operating room at an academic institution where we could have up to 8 people with the anesthesiologist, the anesthesia resident, the surgical attending, the surgical resident, the surgical tech, a surgical tech student, a nurse, and someone who's learning, as well as a possible med student. And we often have that many people in our operating room at Rush. And we looked at 1 cap per person, 3 caps per person, if somebody was only laundering once a week, if somebody was laundering once a month, just to have some alternative assumptions in there. And so we calculated all of these scenarios just to help people use this data however they felt best. And we had our outputs that you can see in this table, which is kilograms of CO2 use and then kilograms of water. And what the coolest part was, which I sort of mentioned in the LCA to come out of this, was that we actually did a break-even analysis. So we looked at the number of times a cotton cap needs to be reused before it became more favorable to use that cotton cap than that bouffant cap. Because what we found out is that the amount of water that it takes to grow cotton and then bleach cotton, make cotton, and then wash those cotton caps, it's not just 1 cotton cap is better than 1 bouffant cap. So we have to reuse our cloth cap about 23 times before it's less harmful on the environment than a disposable bouffant cap, because that disposable bouffant cap just uses those polypropylene granules and then use some heat to make a cap. So if you had to just do a head-to-head comparison, a disposable bouffant cap, if you just look at that number of 1 cotton cap versus 1 disposable bouffant cap, it'd be better to just use 1 disposable bouffant cap. But when we get into the realm of 1.2 million caps used at our institution per year, you can see that we only have to reuse that cotton cap 23 times before it becomes much more favorable than using a disposable cap. And so there's some nuance to this, and I think this provides the nuance because nobody really trusts anything that's black and white. And these numbers can shift. We ran this as well, saying that, hey, let's use a more sustainable material, such as a bamboo cap, and this number drops drastically to about needing to use a bamboo cap 9 times before it's more favorable than a bouffant cap. And that's because bamboo uses much less water than cotton to grow, but still uses water in that laundering process and energy in that laundering process, as well as, the energy that it does take to harvest the bamboo plant and then transform it into fabric. So just some ideas out there for that. And here is the most exciting portion of it. So this is the impact that you can get from a life cycle analysis. And so what we looked at here is the dailies, or the disability adjusted life years, from a single use versus a reusable cotton cap. And what you can see is almost in every category, harm to human health, global warming, ozone depletion, ecotoxicity, marine toxicity, land use, all of these kinds of things. Almost in every single case, a single-use bouffant cap was much worse for the environment than a reusable cloth cap. So these are numbers that start to then mean something to people, such as ionizing radiation, harm to human health. And depending on what part of the country you live in or what the concerns are of the people around you, these are numbers that you can then use to sort of translate to people, to other people who may not know as much about the environment, all of this data you've done into a succinct way. And so what we sort of got from the final data, sort of our for lack of a better word, our elevator pitch was, hey, when we use the amount of bouffant caps that we're using here, and when we we use these bouffant caps instead of our cotton caps, here is what happens. Here's the data, and you can see that this is an easy thing that we can just post up anywhere, that we can use to educate people, use to educate the people who make the decisions in the C-suite, use to help hopefully really drive policy change. And the reason that we found out at Rush that we couldn't go back to cotton caps is it's up for interpretation code that's part of Illinois law that says that anything that's worn in the operating room needs to be laundered by the hospital facility. And so does that include caps? Does that not include caps? Because there are plenty of things that we wear in the operating room that are not laundered by the hospital. Our scrubs are, but there are plenty of other things that we wear in the operating room that are not laundered by the hospital. So this has become a little bit of a mission for me where now I'm like, hey, this is harming the environment. We care about this. This is harming everyone in terms of these dailies. Can we go back to these organizations that are setting these laws and really get this to tighten up to change this? And this is a state by state regulation, which is why some operating rooms have reusable cotton caps and some don't. So now I had done my first LCA. I was like, awesome. I got all this awesome data out of it. It was sort of hard, but I learned a lot. And I was like, let me sort of think about something that I do day in and day out and see if I can quantify the impacts of that. So what do I do a lot of as a pediatric surgeon? I do a lot of appendectomies. Sometimes I am shocked that anyone in the United States still has an appendix, but we just have a lot of people and it's a common operative condition. So for those of you who may not know, we do over 300,000 appendectomies in the United States per year. So very common operation, but everybody has their variation on getting someone's appendix out. And in this LCA, we specifically only looked at uncomplicated appendicitis, so not appendicitis with an abscess or with perforation or any other complicating factor, just uncomplicated appendicitis, which is a large proportion of these appendectomies that are done every year in the United States. You can do them as an open operation with a small cut in the right lower quadrant. You can do it laparoscopically with the TV camera. I know many people are doing these robotic, and really there's no difference in outcome for an uncomplicated case of appendicitis. There's some small differences in terms of return to work and school for open versus the lap and robot, because obviously you have an incision for an open operation. But there really is no big clinical outcome difference, and I'm sure some surgeons will argue with me, for a healthy person who has uncomplicated appendicitis. But there's such a large variation in technique. And I just wanted to show you a little bit of the different ways that we could do this operation. So the top line is doing this operation with something called an endoloop, which is just a piece of suture that's sort of on the end of this plastic tube. And you use two of these sutures and then use some energy or a cautery device to take down part of the blood supply to the appendix. And the second operation, which I would say is very common in our institution, We use a stapler, a surgical stapler, with multiple reloads on that surgical stapler. And I would say a little bit more common in our adult population, at least with the adult surgeons we work with, is that they use a stapler with a load for the appendix, and then they use a single-use disposable energy device to take down the blood supply to the appendix. And while there's variations in cost, it was difficult to look at the variations in cost because for so many places, we go to multiple different hospitals. You have to, the hospitals need to sign non-disclosure agreements in terms of the cost. So while we can guesstimate what the costs of these things are, we don't know what the actual cost is to the hospital or to the patient because these contracts can vary so widely. And so what we did is, again, this was, we looked at sort of put together a systems diagram of how do we do these three different types of operation. Here's the endo loop operation, so that was just a little suture. Here's when we use a stapler. Here's where we use a stapler, which is a single-use surgical device, with the ligature, which is also a single-use surgical device. Stryker does recycle some ligatures, but at our institution, because of the contract that we've signed, we can't yet buy back those ligatures that can be recycled. So for us, in essence, it is just single use and we throw it away. What's in red are the things that were very difficult for us to find out, / we couldn't find them out, so we excluded them. And I think any LCA that you read should have a diagram like this, which tells you what's included and what isn't included in doing that whole life cycle analysis. And so even though we called the company multiple times to ask them, how are these things manufactured? Where are they manufactured? How do you normally ship to the United States from where they're created or made? Are they made in the United States? We just simply could not find out that information. There isn't a big enough desire yet from us as consumers to ask those questions for the hospital to make those things transparent. There are many organizations that work and that know that this is important to us and they do offer this data, but I would argue just having a conversation with the rep at your institution about, hey, how do you manufacture things? Do you have any environmental sustainability data? What is the environmental cost of this? Many organizations do these LCAs in-house, such as Intuitive Surgical, which is is sort of the major robotic player on the market. They have a sustainability department that does these LCAs. They aren't always available to us easily, but I think we, as sort of the consumers of this product, it's on us to ask for that information, to signal to these companies that that information is important to us, that can go into the decision making of what products we choose to use, what we choose not to use, what we ask for, what we don't ask for. So after we did this LCA, and I'll spare you all the gory details of the LCA, we basically had this slide at the end. So when we looked at our outcomes in terms of greenhouse gas emissions and human health in terms of disability adjusted life years, what we found, no shocker, is that using 2 single-use surgical devices is way worse for the environment, for our patient, for our own health, than using the thing that uses less material. And while this example is sort of like, yeah, duh, of course, we didn't really have numbers to put to these things before. So now we have numbers that we can multiply out times that 300,000 operations done just in the United States to how many appendectomies are done in the world to really get a sense of the impact that's being created by these devices that we're using, by these choices that we're making, especially when there's no difference in clinical outcomes. If there's no difference in clinical outcomes, why is this not a target of this is high value care instead of being expensive, low value care? So there's a couple different ways to frame it and think about it, but if we don't have the numbers, we don't have a discrete framework to put it in. So my next steps are doing a life cycle analysis of non-operative antibiotic versus operative management of appendicitis. Non-operative management has become, it was sort of actually popularized about 15, 20 years ago by some pediatric surgeons at the time in Ohio. And they found that 85% of uncomplicated appendicitis can be well treated with just antibiotics, not needing surgery. And that the caveat to that is that some people say that operative management is still better. It's an area of great debate in the surgical literature. And there are, different things we're looking about it: cost, impact to patients in terms of how long the kids are off school, the parents are off work. For adults, how long they're off work and school, what are the disability, how soon they can go back to work, the complication rate. So there's a lot that goes into this, but no one's looked at it yet. Some people may be looking at it yet, but there's nothing published in the literature yet. What's the environmental impact from this? So I think it's another leg of this conversation, well, not the whole conversation. And there's some definite challenges in this LCA. Pharmaceuticals is a big black box. We know that we have a lot of pharmaceutical waste. We know how it's harming the environment, but really figuring out how pharmaceuticals are made and what their environmental impact is just not an area that's been well studied yet. So if anybody wants to do the newest, greatest thing, I think it's definitely looking at pharmaceuticals. But as you can see, this project has some complex modeling that goes into it. We need to look at reoccurrence rates and data. So we're in the middle of it right now. We're slogging through it a little bit. So I spent a lot of time talking about, what we think as healthcare, what are important to us as healthcare providers? What do we think about the care that we do? But I had a great resident who was like, we're spending a lot of time asking surgeons what they think, asking nurses what they think, but have we ever really asked patients what they think? Like, what do our surgical patients think about environmental sustainability? And it was sort of a light bulb moment to me. I was like, whoa, we haven't really asked them. We don't know where it is, how important it is to them, where it is on their priority list. And so we're like, okay, let's ask them. So we did a survey of adult patients in an outpatient general surgery clinic. So these were patients, just all comers who came into our outpatient general surgery clinic who are waiting to be seen. And we just approached them in the waiting room and said, hey, do you mind filling out this quick survey for me while you're waiting? If you get called called back to go see your doctor, of course, stop the study. But what do you sort of think about these, about environmental sustainability? And so I was actually and so we interviewed 100 patients. I was shocked. 75% of them were concerned about the impact of the environment on their health. I didn't really know what this number was going to be, but I honestly didn't think it was going to be that high because people were there for their health care. And I didn't really think that, because I had never put it together, my care that I was getting was directly linked to the environment as a patient. I had never put those two things together. So I was like, wow, people really care about this. And this was just a random sampling of the population. And a lot of these patients, and this was just done in partially in 2023, partially in 2024, so it's not that old. But they also agreed that the healthcare contributes to climate change. And I didn't realize that there was so much awareness around that because I didn't have that awareness, 6 or 7 years ago. And we asked them some leading questions, but we were trying to get our work sort of funded and out there. And we asked them, how much do you care that you would choose a health system that promoted environmental stewardship, and that was actually working to reduce its environmental impact? And 87% of them were like, yeah, we would pick a hospital that's talking about environmental stewardship. And this was surprising to our CFO at the time, and surprising to our patient experience team, that they're like, wow, people really care about this, and that they care that the hospital is doing something about it. And many of them also thought that they should publicize what the hospitals are doing in terms of environmental sustainability efforts. But you can see a much smaller percentage when we actually went from the macro back down to the micro level, about if you had a choice in an operation, do you want to know about the environmental impact of the operation that you're going to pick? So if you have a choice between laparoscopic and robotic, do you want to know about the environmental impact of that? And would that change what operation that you picked? And so only about 37% of them were interested in knowing about that. And it was really interesting that at a very much a macro level, people cared about it. But we also called some of these patients later to, do a qualitative study a little bit more about their views. And everyone was like, yeah, it's really important. But, if I needed emergency surgery, I'm not sure that I'd want that information to factor into my decision making. So I think there's still a lot of work to be done in this area. And what our patients think about this and what do they want to know? And I just wanted to talk to you a little bit about what my future directions are and where else I'm going with this. Is that we are currently working on a project to look at surgeon perspectives, and then we'll branch it out into the entire operating room on an environmental impact label, very much like a nutrition label, to see if that will decrease our use of sterile single-use disposable devices. So we've made these environmental impact labels that I think of like nutrition labels, and are showing them to people to sort of see if what this means to them. Does this label mean anything to them? Will they do anything with them? Will it actually change practice patterns? So we're sort of all in the mix of that right now. So thanks for your time and attention today, but I hope I met my objectives to discuss some of the barriers and solutions that we have to our sustainability work and how we can get around that. Discuss sustainability through a research lens, and also discuss the utilities of using LCAs in sustainability research. So thank you so much for your time and attention today.
Thank you, Ami. That was spectacular.
Thank
And
you.
great to hear all the work you're putting into LCAs. I'm really eager to see the LCA about oral antibiotics versus operative intervention for appendicitis. It's not something we do a lot of here, but it is something that I spoke at a conference with one of the early adopters in California at advocating for antibiotic therapy. My wife, who's probably watching, is an infectious disease doctor. And I would say her anecdotal experience has been go to the OR, don't give them
Yeah,
antibiotics.
yeah.
But I think there's a lot still to be fleshed out. And I think when you factor all the different things that go into that decision, um, you know, I don't think we're accounting for all those factors in the discussion right now. Um, I had some questions for you personally, and then I will look to the Q&A session to see. So if you guys have questions for Dr. Shah, please post them in the Q&A, and I'll start going through them. I had a question about your comments about Stryker. Stryker has a big sustainability program, and they're probably our biggest partner right now in reprocessing collections for especially things from the OR. Um, have you talked with your Stryker reps about changing your contract to allow for more purchasing of reprocessed devices? Because I think this is sort of a way we can really have an outsized influence as clinician leaders is working with vendors and suppliers, though it is hard to go from your local rep to the organization itself making big changes.
Yeah, absolutely. So I'll tell you, in this work, I have uh, I'm trying to say this in a way that doesn't sound funny, but I have tried to make two groups of people my new best friends. One for the knowledge that they have, and then the other for their ability to actually make change. And one of those groups is actually our procurement, or the people who buy our supplies team. And they're really interested in this, and they want to save money for the institution. They want to cut waste. And as people, especially at Rush, they really care about the environment, and we've had a really strong partnership. And what's been fascinating to me is they're like, oh yeah, we could totally decrease the environmental impact from these things, but then we're told that the clinicians aren't for it. And I'm like, what? No one's ever asked me that question. And so by partnering with these people that I literally before this had no idea how supplies showed up in the OR. It was just sort of like magic. They showed up when I needed. Having those deeper conversations with them and giving them clinical context and saying that these things are true and not true has been really helpful. However, we signed a 3-year can't break it contract with Stryker. And so that contract is coming to an end in about 1.5 years. And so I think because we've continued to have these conversations with Stryker, they collect from us. We're a big collection site. They give us how much cost savings we would have had if we rebuy the reprocess things. I do think that there'll be much more of an appetite for when the new contract negotiations happen to include that within that. And the other people that I've very much tried to make my best friends, which is like your wife, is infection prevention and control. Like I knew they existed. I knew they had some important role in the hospital, but I really didn't know what it was. And it was actually people that I met at CleanMed. They were like, IPC does this, IPC cares about this, IPC really cares about the environment. And I was like, whoa, mind blown. Like these are my best friends in terms of making change and making sure that we are really putting patient safety at the forefront, which I also think is environmental sustainability. But, you know, I'm sure you've seen the NHS Gloves Off campaign about like not about using disposable gloves appropriately. And IPC is like, yeah, we would love to have people wear less gloves and just wash their hands. And so it's been a really strong partnership. So for everyone at their institution, I think I saw something about like how do you sort of change the culture and get people to think about this. It's really about creating that team and getting people that you wouldn't normally interact with all on board, because now we've got sort of this critical mass of people talking about it, thinking about it in all these disparate spaces, that it's really becoming something that's factored into everything. We just had a merger of I'll stop talking in a second, a merger of of 3 different medical groups into one medical group. And so everybody has to buy new scrubs. All the employees have to buy new scrubs. I was like, hey, can we put a blurb that specifically look at this vendor or that vendor have more environmentally appropriate cloth choices for our scrub vendor, for our preferred scrub vendor. So we were able to get that in there, and that's just because I keep babbling on and on about the environment.
Do you think, well, let me just say from my perspective, I'm saying this out loud for me to hear, as well as anybody else who's working in sustainability. When you run into that roadblock where like you can't get the contract change and it's in place for 3 years, there's so many other opportunities to look at. Like you just can't find frustration in that. You just have to be able to pivot, because otherwise you're going to get really burnt out and frustrated in sustainability work if you just keep hammering against that one thing that you can't change, because there are equally powerful opportunities for change outside of that. So I would just encourage anyone who's working in sustainability to look at that and say, okay, that'll be my project in 2027. And I'll come back to that then. I'll have all the foundation because Dr. Shah is going to make some other LCA about ligature that's going to say that it's better than to use reprocessable than OEM or original manufactured equipment. So like that's how you keep the fight going, is by giving yourself some grace and pivoting to things that are accomplishable now. Next question I had for you, I lost my train of thought. You're in an academic setting, and you talked about some of the residents you're working with. When you are doing academic discussions and working with learners, are you bringing the carbon footprint and the disability adjusted life years of the interventions that you're doing into your discussions so that these learning physicians can go off into the world and have some knowledge? Like, is that a incorporated part of your residency training program, or is it just if they get to work with Dr. Shah that they learn about it?
So I'm really fortunate that we have our medical school curriculum has sort of switched to, I think, like everyone's has, like the different types of people that we want them to be, advocates, this, that, whatever. And it's very much built and baked into the curriculum of our medical school. Not as much as, of course, it could be, because the amount of knowledge that students have to learn nowadays is mind-boggling. But it's definitely a discussion point brought up as a separate, sort of week thing where they focus on the environmental impacts, especially in terms of like equity and inclusion. And so I think we're fortunate to do that. Our medical school has been participating in the Planetary Health Report Card for a while. But what's really encouraging to me is that at our institution, I just sort of started it and just did it and asked for permission later. But we started for surgical residents, basically a climate fellowship where basically they do a research project with me. We've incorporated it into our quality and safety metrics for the year within the Department of Surgery. And so the project that my current resident is working on, who's the Strives Fellow, it's Surgical Training and Environmental Research Fellow, is looking at the amount of lab tests ordered in our post-operative colorectal patients because she wants to be a colorectal surgeon. So really having that grassroots effort of someone caring a lot about that and then trying to find, we had people doing residents doing sustainability work for 3 years prior to that, and we didn't have a name around it. And someone's like, well, why don't you put a name around it? I'm like, genius. And so I think doing those things really raises the profile, and all the other residents are like, oh, that's so cool. Thanks for doing that. Like, we want to be involved in that. So, and we're also participating in the Planetary Health Report Card that's now starting for residency programs, which I think is for surgical residency programs, which is really neat. So yes, a lot of word of mouth, a lot of grassroots, but I think definitely becoming more normalized and something that this population cares about. And the quality of the med students coming in, I'm always like, I can never get into med school nowadays with comparing with these people where they are. So many of them are coming to us with rich MPH backgrounds, rich just having done sustainability work, cared about sustainability work, cared about the climate in some ways, that I'm very much lucky to be able to lean on their expertise because I don't have the knowledge base they have.
I love the survey data you had that showed that patients cared so much. Is that something you think you have seen replicated at other sites and replicated at the clinician and nursing level? Because I think it is critical for hospitals to see that their potential and current employees care so much about this. If you could just share what you know about hospital employees and other studies that have done this with patients.
Yeah, absolutely. At our institution, we actually formed an employee resource group specifically around environmental sustainability. And I think that employee resource group, I didn't have anything to do with it. I'm just a member of it. Was one of the fastest growing groups at our institution. I think it's got over 300 people that are part of it that are like, I see waste all around me. How do I stop this? How do I put the brakes on this? How do I make this place better? I cannot handle the amount of waste I see. So we've had a lot of exciting projects and ideas coming out of that, that are people who may feel like they don't have the power to make the change, but are actually the people that have the power to make the change. For instance, in our endoscopy suites, one of the managers of the endoscopy suites noticed how many plastic bags we were wasting in terms of IV fluids. Was like, can we do something about this? And so now we're recycling the plastic IV bags, which is amazing and going to be a huge volume for the amount of colonoscopies and EGDs that are done at our institution a year, including at all our ambulatory sites. So
Where are you recycling the bags? I'm curious to see if that's
I will send you an email about it later
yeah,
because it's
please
a
do.
little complex. Yeah.
Yeah. I mean, plastic recycling, I think, is something that is probably the number one ask I get, but probably the hardest thing to make me feel is actually impactful just because of the murkiness about what's actually happening to that plastic material. But like, we generate so much plastic waste, um, in the ER, in the OR, in the ICU. Um, and we've been talking a little bit about redoing a waste audit that we did a few years ago, and I think that would be great to kind of see where we are.
Yeah.
I have a question from the crowd that I just wanted to sort of bring in before we close. Um, it's about culture change in the OR. And I think you've answered this to some degree with talking about it, normalizing it, studying it, and changing your own individual practice. But how do you find it's most effective to bring this work into the OR so that people that maybe haven't heard of this are more conscious of their environmental impact and active in changing their practices to be less impactful.
Yeah, I think it's really talking about it. Like, and the other thing is, I will say, I think everybody that works in the operating room, this may be also medicine in general, is highly competitive. We have made this into competitions, like which team can, recycle the most amount of blue wrap, which team had can do this operation the cheapest. And that data has been out there that when you compare surgeons in terms of cost and time, everybody's cost and time drops because they're like, oh, I want to be the fastest, I want to be the most safe, I want to be the cheapest. And so like gamifying it in a way and making it fun has been, I think, a big component of that. And a lot of that work has been led by our very strong clinical nursing team in the operating room who are part of the employee research group, the environmental sustainability research group.
It's great. Well, I appreciate your time today. Thank you for an outstanding lecture about how we can green the OR and how your career has kind of gotten to this point. I think you've been a role model for me, and I really love that we've gotten to meet and hear all these great things that you're doing. Um, Please join us again on October 8th with Dr. Lisa Patel, another hero of mine, and a pediatrician. We'll be talking about her journey in the climate and health space. And thank you again, Dr. Ami Shah, for a great presentation.
Thank you, Dr. Sims. Thank you, everyone.